Okay, so this is a case study on glaucoma. The patient is Jane Doe, a 62-year-old female who's presenting for a routine eye examination. She has a history of type 2 diabetes and hypertension, and over the past 6 months has started to notice a gradual decrease in her peripheral vision, occasional blurred vision, the presence of halos around lights, and especially she's noticing these symptoms when driving at night. She reports gradual peripheral vision loss, which she initially did not notice until she started having difficulty navigating the dim lighting, and it became more pronounced. She also experiences mild eye discomfort and occasional headaches, but no acute pain or sudden vision changes. She also mentions seeing halos around lights, which suggests corneal edema due to increased intraocular pressure. The patient has a family history of glaucoma, as her father was diagnosed with primary open-angle glaucoma in his 70s. She also has longstanding hypertension and diabetes, both which are significant risk factors for glaucoma development. She denies any eye trauma, previous ocular surgery, or steroid use. On physical examination, she had several findings that were consistent with primary open-angle glaucoma. Her intraocular pressure was 26 in both eyes, which exceeds the normal range of 10 to 21. Elevated IOP is a major risk factor for glaucoma and contributes to optic nerve damage by compressing the retinal ganglion cells. She also had increased cup to disc ratio on her fundoscopic examination, which indicates progressive optic nerve damage due to the loss of retinal nerve fibers. This structural change is a hallmark feature of glaucomatous optic neuropathy. She also had loss of peripheral vision on a visual field testing, which confirms progressive optic nerve dysfunction. Glaucoma typically presents with paracentral scotomas and accurate visual field defects, which worsen over time if untreated. She also had no acute signs of angle closure glaucoma, such as mild dilated pupils, corneal clouding, or severe eye pain, which are all indicative of an acute glaucoma crisis and require further emergency intervention. All of these findings strongly indicate primary open-angle glaucoma, the most common form, which progresses insidiously and often remains asymptomatic until significant optic nerve damage has occurred. Based on all of this, and my diagnosis is consistent with primary open-angle glaucoma. POAG is a chronic progressive optic neuropathy associated with increased intraocular pressure, gradual peripheral vision loss, and optic nerve cupping. In POAG, the trabecular meshwork becomes obstructed, leading to a gradual decrease in aqueous humor drainage. This results in a slow increase in IOP, which subsequently compresses the optic nerve fibers and causes irreversible vision loss. Unlike acute angle closure glaucoma, POAG progresses silently and without any acute symptoms, which makes routine screening crucial for early detection. Although this is primarily diagnosed clinically, some diagnostic tests can help confirm the diagnosis and assess the severity of optic nerve damage. The first one is tonometry, which measures IOP. Elevated IOP is considered above 21 and supports the diagnosis, but this is not always present, especially in normal tension glaucoma. Next, a fundoscopic examination evaluates the optic disc for cupping, which is increased cup to disc ratio, retinal nerve fiber thinning, and hemorrhages. A cupped optic disc is a hallmark feature of glaucomatous optic neuropathy. Visual field testing assesses her peripheral vision loss, which is another characteristic. Optical coherence tomography measures retinal nerve fiber layer thickness to detect early changes, such as thinning of the inferior temporal retinal nerve fiber layer, which is often seen early in glaucoma. Gonioscopy differentiates open-angle glaucoma from angle closure glaucoma by evaluating the drainage angle between the iris and the cornea. In POAG, the angle is open but obstructed by the trabecular dysfunction. Although glaucoma is irreversible, treatment focuses on reducing that intraocular pressure and slowing the disease progression to prevent further optic nerve damage. The primary goal of treatment is to enhance aqueous humor outflow or decrease aqueous humor production, which both effectively will lower IOP. Some topical medications are used, such as prostaglandin analogs, such as latanoprost or bimatoprost eye drops, which work by increasing aqueous humor outflow. This is the most effective first-line therapy for POAG. Additionally, beta blockers, which reduce aqueous humor production in the ciliary body and can help lower IOP. These are used cautiously because they can have effects for respiratory or cardiovascular conditions. Next is carbonic anhydrase inhibitors, such as dorzolamide and brinzolamide. These reduce aqueous humor production and are typically used as adjunctive therapy with some of the other eye drops. Alpha-2 agonists, such as bromodenide. These medications lower IOP by reducing aqueous humor production and also increasing uveoscleral outflow. So it's a dual action therapy option. If patients are unresponsive to medication, laser therapy can be considered, such as laser trabeculoplasty, where aqueous humor drainage is improved through the trabecular meshwork, which reduces IOP without requiring any incision, or laser peripheral iridotomy, which is used for angle closure glaucoma and is a technique that creates a small opening in the iris to relieve fluid buildup and prevent acute attacks. In the most advanced cases, surgical intervention could be considered, such as a trabeculotomy, which creates a new drainage pathway to lower the IOP. That's typically used when medications and lasers are ineffective. Next is minimally invasive glaucoma surgery, which is a fairly newer alternative and offers a safer, less invasive approach compared to the traditional surgeries, but is still effective in reducing IOP in some mild to moderate cases. It's important to remember that early interventions are essential to prevent irreversible vision loss. So the most important treatments include routine ophthalmologic evaluations, including for those that have a risk, such as those with a family history, diabetes, or hypertension, to catch it early on. Long-term management requires close monitoring and includes ophthalmologist visits, optometrist visits, and making sure that they're on the proper pharmaceutical regimen.